speaker is Professor Chris Rayner, a gastroenterologist and again a great supporter of Diabetes SA. Chris Rayner is a professor in the School of Medicine, University of Adelaide, and a gastroenterologist at the Royal Adelaide Hospital. He's also a member of the Centre of Research Excellence in Translating Nutritional Science to Good Health, based at the University of Adelaide. His major research interest concerns how nutrients interact with the gut to regulate flow of contents through the stomach and intestines and to influence control of blood glucose in people with diabetes. His group has recently been investigating the benefits of taking whey protein drinks before meals in people with type 2 diabetes. Please join me in welcoming Dr. Chris Rayner.
Well, thanks very much, Fiona, and it's a great pleasure to be here this morning, and I thank Diabetes SA for their invitation to speak. Well, Matt's told you a lot about life and death issues, and I want to reassure you that I'm not going to do so. I want to borrow a quote first used about football. A good digestion is not a matter of life and death. It's much more important than that. Now, a lot of you are probably going to think that I'll spend most of my time talking about the nasty things that diabetes might do to your gut function. And I'm going to talk a little bit about some of the things that diabetes does to gut function, but what I want to also impress on you is the fact that the function of the gut has a big bearing on blood glucose control after meals. And for years, people haven't really considered that. Diabetes specialists don't think much about the gut. I think that's all changing a lot because if you think about it, the gut is where you get your carbohydrate from the outside world into your body, so its function is going to be absolutely critical in what happens to blood glucose control after a meal. I will, however, talk about some of the things that diabetes does to gut function. I'm going to spend a bit of time talking about stomach function, and some of you might have heard about something called gastroparesis, so I'll talk about a little bit about that, but also some other aspects of gut function, oesophageal function, and particularly reflux disease, and also things people don't like to talk about, function of the small and large intestine, things like diarrhea and constipation, nasty things like that that are best kept under the table. Well, as I said, the emphasis for diabetes over the years has been thinking about measuring your fasting blood glucose. And for a proportion of people with diabetes, that's very important because the people who are badly controlled will have high fasting blood glucose, and that certainly has to be addressed. But for the majority of people with diabetes, their blood glucose control is not that bad, but it does need tightening up a bit. And their fasting blood glucose is not too bad. And what we really have to focus on is the rise in the blood glucose after meals. And think about the way that we eat food in modern society. We don't eat once every 3 days like you might have done in a hunter-gatherer setting. We're eating food throughout the day. We have 3 main meals. Often we might have snacks in between. So if you're thinking about just focusing on fasting blood glucose, that doesn't make up much of the 24-hour cycle at all. So breakfast here, you've got food in your stomach, that then empties, it's being absorbed from the intestines, even while you're having lunch, so then you've got more food in your stomach, more absorption going on. Dinner time, more food in the stomach, more absorption from the intestines. There's only about 3 or 4 hours where your gut's really empty and nothing's coming in from the gut before breakfast. So really we should be interested in what's happening after meals. There was a very sensible question about the effect of blood glucose control on heart disease, and it's very true what Matt said, that this is a controversial area. But one of the topics that's emerged in recent years is the idea of glycemic variability, so how much the blood glucose fluctuates. And a lot of you will know that your doctors spend a lot of time looking at this value called the HbA1c, and maybe they measure it every 3 months or so, and it gives an overall guide as to how good your blood glucose control has been. And the reason that people are obsessed with it is because it's been shown to relate, as Matt said, very clearly to what's called the microvascular complications, the eye disease, the kidney disease, the nerve disease. Probably does relate to heart disease and strokes. The relationship's been slightly less clear-cut. But what's emerging is that even if people have got the same HbA1c, they may have quite different blood glucose profiles. So here's one person who's fluctuating with meals like that. Here's another person B, much bigger fluctuations, and we're now starting to realise that this probably has much greater implications for things like vascular disease. So that's a hot topic at the moment. So I think this slide really tells you about why the gut's so important in this area. And when you ingest a meal, it travels down the esophagus pretty quickly and then it enters the stomach. And the stomach plays a really important regulatory function because you don't want to dump all this meal all at once into the intestines for absorption. You want to start processing it, grinding it up into small bits and releasing it in a very carefully graduated fashion into the small intestine. So the stomach's really able to quite tightly control how many calories per minute are being released into the intestines, because it's in the small intestine that a lot of the digestion and the absorption of carbohydrate occurs. When the food enters the small intestine, it doesn't just get absorbed, it also interacts with cells in the small intestine and it releases hormones from those cells. And these are really important because they do a number of things. They signal up to the brain to say, oh, there's food there, I think I'm full, I've had enough. That's important. And if you stop eating more carbohydrate, that's going to keep your blood glucose down. Some of these hormones also play an important role in stimulating your own insulin secretion from the pancreas. So if you inject glucose into the bloodstream, you'll get a much lower insulin response than if you give the glucose by mouth. And that's because these hormones are being activated and stimulating extra insulin secretion. And the other thing these hormones do is they then feed back on the stomach function to alter the emptying of the stomach. So they're part of the mechanism that creates this really tight control of how quickly nutrients are emptied from the stomach. And they put the brakes, if you like, on too much stuff spilling through all at once. And here's an illustration of what an important effect the rate of stomach emptying has. So in this study, volunteers with type 2 diabetes had a glucose drink. Some of you may have had one of those oral glucose tolerance tests. It's a bit unpleasant. And what happened in this study was we were able to measure the rate at which that glucose drink emptied from the stomach. And each dot on this graph represents a different volunteer. And along this axis, we've got what percentage of that glucose drink was emptied after 1 hour. And on this axis, we've got how big the rise in blood glucose was. And you can see the people who empty a lot of the drink at 1 hour have a much higher rise in their blood glucose compared to the people who empty less of the drink in 1 hour. So it's a really major relationship between rate of stomach emptying and blood glucose response. And you can actually, if you want to experimentally, you can manipulate the blood glucose value by giving drugs that affect stomach emptying. So in this study, again, these are people with type 2 diabetes. This is what their blood glucose does after a test meal. Now, if you were to inject a drug which makes your stomach empty faster, and many of you will have heard of this antibiotic, erythromycin, that as well as being an antibiotic, it actually forces the stomach to empty more quickly than it normally would. Look at what happens to the blood glucose. I'm sorry about the unit. These are in the units that Americans like to use, so they're different from the ones you might be familiar with. But look how much bigger the blood glucose response is. And in the same people, on another day, if you were to inject morphine, now morphine is something that slows the emptying from the stomach. It actually slows the movement of contents right through the gut. look how that blood glucose response is flattened. So you can manipulate the emptying of the stomach and have big effects on what the blood glucose response is. And we can use that knowledge about mechanisms of stomach emptying for beneficial effect. So we've got the idea that maybe you could actually give a small dose of a nutrient a little bit in advance of a meal and actually harness those gut feedback mechanisms to improve your blood glucose response when you actually eat the main meal. So you could use probably a dose of carbohydrate wouldn't make a lot of sense because that will put your blood glucose up itself. You could use a dose of fat. We don't necessarily like to have a lot of fats in our diet if we can avoid them. The thing we've focused on is protein. Protein's quite a nice thing to use. Whatever you choose, it will empty into the small intestine and it will stimulate release of, I've put some of these hormones down. You don't need to worry about these too much, except that one of the ones we've focused on is a hormone called GLP-1, and you may well not have heard of this, but it is important in diabetes because there are synthetic versions of this that are now available as treatments for diabetes. So you release these hormones that have those effects I talked about earlier. They make you feel full, they stimulate some insulin secretion, and importantly, they slow the emptying of the stomach. So by the time you then come to eat the main meal, you probably want to eat a bit less. It doesn't empty as quickly into the small intestine, and you've already got some of your own body's insulin response there to lower the blood glucose response to that meal. So the way we tested this, we had some very helpful volunteers who had type 2 diabetes who came into our laboratory, and we tested them under a couple of conditions. We gave them a low-calorie beef-flavoured soup, and one day they had some whey protein added to that soup and one day they didn't. And they took that soup about 30 minutes before the meal. Then, after taking the soup, we gave them the test meal. And you might argue this isn't necessarily a normal sort of meal in itself, but it's something, one component of what you might normally eat. It's a high carbohydrate meal. It was a mashed potato meal. And we were able to follow the emptying of that meal from the stomach over the next 3 hours. And during that time, we also took blood samples on a regular basis. And here's what we found. How did we measure stomach emptying, you might ask? Well, in this study, what we did was we put a very weak radioactive label in that mashed potato meal, and using a special camera like this positioned outside the body, we could track the emptying of that meal from the stomach. So here's the kind of image we get. That's the stomach there. That is the meal lighting up in the stomach on that camera image. And then we can see some of it's emptied into the duodenum here. And over time, we can see how much meal's retained in the stomach over that 3-hour period. We've got other ways of measuring stomach emptying. We've got, for instance, a much easier breath test method that doesn't involve any radiation exposure at all. So we use that a lot in our studies if we can. But this is a very accurate method for some experimental testing. So what did the whey in the soup preload, what did it do to the response to that mashed potato meal? Well, if you didn't have the whey, here is the stomach emptying. So this is time, and this is how much is left in the stomach, and you can see how the amount left in the stomach decreases over time. And if you had the dose of whey 30 minutes before that mashed potato meal, you can see that the decline in how much is left in the stomach is much less, so the emptying of that mashed potato was much lower when you'd had the whey in advance of the meal. Did we stimulate some of those hormones that we wanted to? The answer is yes. So here's measurement. We measured from the blood how much of that GLP-1 hormone was present, and you can see if we only gave the mashed potato meal, yes, there's some of that hormone produced, but if we gave the whey protein before it, even before the mashed potato meal's given, we're stimulating that GLP-1 hormone and we're getting much higher levels of that hormone than if we just gave the potato meal. And the most important thing is, what did that do to the blood glucose response? Well, here you can see what the blood glucose did with the mashed potato alone, And here's what the response was if you gave the whey beforehand. You can see there's a good 2 or 3 millimoles per litre difference in the peak blood glucose response. So that's very impressive, isn't it? Of course, you might say, well, in order to get that effect, I've had to take some extra nutrient before the meal. So this is a real balancing exercise, isn't it? You've got an improvement in blood glucose, but the downside is that you're taking some additional energy intake. You'd be particularly unhappy about that if it was a fat or a carbohydrate, but even a protein, you might be concerned in the long term that you're going to gain weight because of that approach. Now that probably isn't the case because it's going to make you eat less at a meal, and overall our studies so far suggest that there isn't weight gain if you adopt this approach, at least over a number of weeks, but it's certainly something we need to study. The other thing though we're trying to refine at the moment is how small can you get that protein dose down to and still get the beneficial effects. So that's something we're really refining to roll out as a useful strategy that a lot of people with diabetes could maybe get this supplied from a pharmacy and use on a regular basis. So that leads on to the question, what happens to stomach function in people with diabetes? And this has been a research focus in Adelaide for a long time now, and this work goes back 25 or 30 years. So one of my mentors, Professor Michael Horowitz, studied a lot of people with long-standing diabetes way back then. This is the emptying of a minced beef meal measured by the technique that I talked about earlier. And this is the emptying of a sugary drink that went along with that meal. And you can see here are some healthy people, and there's quite a big range at which they emptied both the beef and the liquid sugary drink. And here's the range of emptying in people with long-standing diabetes for solids and for liquids. And you can see that there's much more variation between people with diabetes, but also there's quite a high proportion, maybe 30 or 40% of people with diabetes empty abnormally slowly, so outside the normal control range. There's 1 or 2 people who empty abnormally quickly. So there's quite a bit of variation in stomach emptying in people with diabetes. Some people may have heard about this term gastroparesis. So a common definition of this condition is that it's abnormally delayed stomach emptying in people who don't have a mechanical blockage of the stomach. So it's a problem of stomach function. And to understand gastroparesis, we need to think a little bit about the different regions of the stomach. And this is a really beautifully intricate organ in how it works. When you eat a meal, a lot of the solid component gets accommodated in this bit up the top called the fundus, and the fundus relaxes in order to accommodate a meal, and gradually it starts to contract more as the meal empties. There's the bit down here called the antrum, which is in the bottom third of the stomach, and it's very muscular. It grinds the solid particles up into bits that are 1 or 2 millimetres in size before they empty out, and it pumps the contents out of the stomach. And there's a ring of muscle at the outlet of the stomach called the pylorus, and that can change its contractile nature to vary how much resistance there is to the stomach outflow. So you've got all of these things working in a coordinated fashion, and they're also influenced by feedback, as I said before, from nutrients that are interacting with the small intestine and making hormonal and nerve signals that affects the function of all of those bits. So if you've got these things that aren't working in a coordinated fashion, or any of the components that are going wrong, you've got problems with stomach emptying, and that's what can happen in some people with diabetes. Another fascinating thing is what controls all of this. What we do know is that there are specialised cells, and there's a particular group of them up here high in the stomach. The cells are called interstitial cells of Cajal. Cajal was a Spanish physiologist who lived in the 19th and early 20th century, and he documented a lot of things in the neurological system. These are specialised cells that set the underlying rate of contraction of the stomach. Many of you will have had electrocardiograms or ECGs recorded of your heart's electrical activity. Believe it or not, you can record your stomach's electrical activity from similar electrodes over the belly, and you can record this 3 per minute cyclic wave that goes on in the stomach, and it controls the maximum rate at which your stomach can contract. If your stomach doesn't work properly, what are the consequences? Well, naturally enough, you might think it could give you symptoms, and certainly it can. So it might make you feel nauseated, it might make you feel bloated and full, and you might vomit. Also, it might interfere with your nutrition. If you've got nausea, or if you're feeling your appetite's poor, if you're vomiting, you're not going to get nutrients in. It could cause problems absorbing oral medications, even oral anti-diabetic treatments. If you're emptying them slowly, they're not going to work as quickly. And one of the important things from what I've shown you already is that you can imagine if your stomach is not emptying in the right way, that's going to interfere with your blood glucose control. And this is especially a problem in people who inject insulin for control of their diabetes. Because if you're expecting that a meal is going to release carbohydrates into the body and you inject insulin to try and match that, what happens if it empties too slowly? The carbohydrates aren't going to get absorbed quickly enough. Your blood sugar will go low too quickly from the insulin, so it's going to be hard to get that match right. What about the symptoms that might result? Do people with diabetes have more symptoms than average related to the gut? Well, the consensus seems to be that's probably the case. It's a difficult area because a lot of the time these symptom questionnaires are done in highly specialised hospitals with a special interest in diabetes and the gut, and they have patients coming there that have these sort of problems. So yeah, you might find that there is a high rate of symptoms, but even if you send out questionnaires to the community, people with diabetes do seem to have a bit of an increase in gut symptoms over what we might call control people. And here's one example of a hospital-based survey, and you can see that compared to non-diabetic control subjects, people with diabetes had a lot of symptoms that were more common: poor appetite, filling up easily, nausea, distension, vomiting. So these are all issues in people with long-standing diabetes particularly. If the stomach's not emptying normally and you've got a lot of symptoms, what's the relationship between the two? Is it a strong relationship? This figure is generated from some data in our laboratory some years back, and each dot there represents a different patient, and you can see along this axis is the rate of stomach emptying of a meal, and along here is how many symptoms people had related to the gut. And you can see that for some people, these people have very slow, abnormally slow stomach emptying. Some of them have got quite a lot of symptoms, and there is a relationship between number of symptoms and slowness of emptying. So if your emptying is slower, you're more likely to get you're more likely to get more symptoms. But it's not a very strong relationship. The relationship is a little bit weak. So not everyone with symptoms has got abnormal stomach emptying, and you might have abnormal stomach emptying and very few symptoms. So there is a relationship, but it's not the only factor. There are other things going on causing these symptoms. For example, here's some work I did a number of years ago where some people with type 1 diabetes allowed us to put a little balloon into their stomach and inflate it with air. And we measured what symptoms they had compared to non-diabetic people. And you can see that things like fullness, these are the scores that they reported, fullness and nausea increased much more in the people with diabetes compared with the healthy controls when we inflated that balloon in the stomach. So there also seems to be an abnormal sensitivity that is at play. What causes gastroparesis? We're getting a lot of useful information out of a group in the US, which is a multi-centre consortium of centres that have got a special interest in this. And some of these patients, they've actually been able to do full thickness biopsies of the stomach in people who have to have operations for their stomach disorders. So we're getting a lot of information about that. Now, There can be a problem in some people with the nerves supply the gut. Some people might have heard the term autonomic neuropathy. So that's a factor in some people, but not all. The nerve transmission between nerve and muscle fibres can be a problem in some people, and some of the transmitter substances can be at fault. And those pacemaker cells, those interstitial cells of Cajal that I talked about, they seem to be deficient in either number or function in a lot of people with severe gastroparesis. So there's a number of different disorders, and we're getting increasing insights into this. The one other factor that seems relevant is that your stomach function actually can vary if your blood glucose goes up and down. So in this study, we had people with type 1 diabetes, and here's the proportion that had abnormal solid emptying when their blood glucose was normal, but if we infused glucose into their system to raise their blood glucose up to high levels, a greater proportion then had slow emptying, and the same thing for emptying of liquids. So changes from moment to moment in blood glucose can actually affect stomach emptying in itself. How do we treat gastroparesis? Well, you might imagine from the last slide that one of the things we want to do is to optimise the blood glucose control. If people are malnourished and not getting enough nutrition in, clearly we have to ensure that they're getting adequate nutrition. And in people at the severe end of the scale, we need close involvement of dietitians to help with this. Things like lower fat, smaller particles in the diet so that the stomach's got less grinding work to do. These are some of the things that can be useful interventions. Naturally enough, we might turn to medications that speed up the emptying from an abnormally slow stomach. And we might also need to consider symptoms in themselves. So we often use medications that specifically address nausea or abdominal pain. So moving on and avoiding running too late, like this person was, I want to turn the thing around and talk a little bit now about what diabetes does to gut function. Esophageal function is one of the things that gets affected by diabetes. So one of the things that can be an issue is reflux. Now, reflux is very common in anyone in the population, but it does seem that people with diabetes are at increased risk. And the symptoms of reflux are what people call heartburn. Often an hour or two after meals, people get a burning kind of sensation in the chest. They might get regurgitation, so they might get a sour tasting acid that comes back up into the mouth. Many people with abnormal reflux actually don't get many symptoms at all, and it can be remarkable sometimes when you look in the esophagus and see nasty damage going on with relatively few symptoms. But certainly it does seem more common in people with diabetes than those without. Difficulty swallowing, where people feel that things don't move through the esophagus very well when they swallow, can also be a problem. There are a number of causes for that, and that's a symptom that almost always needs to be investigated by a specialist if it occurs. But we do know that people with long-standing diabetes, maybe up to half of those will have abnormally slow transit of contents through the esophagus. Another thing that does occur is that candida or thrush can occur in the esophagus, and diabetes is a risk factor for that. So one of the ways that that presents to us is with people who find that swallowing all of a sudden has become painful, and it's something that we can see quite clearly if we take a look down with endoscopy. Diarrhea, one of the things that people don't like to mention. Diarrhea means different things. It might mean abnormally loose stools, it might mean there's too much volume of stool, it might mean going too often in any one day. But if you ask people with diabetes, do they have diarrhea, you find out that it is a problem in some people. So people attending specialised clinics in hospitals, maybe 20% of them will report diarrhea if they're asked. People with diabetes in the community, it's about 15%. You've got to remember that even in otherwise healthy people in the community, about 10% of people report diarrhea as a symptom. So it's extremely common, but probably increased in diabetes. One of the first things that you're always asked is, could medication be contributing? Many of you will have had experience with metformin, and some of you might be aware that that can cause diarrhea. Acarbose is an oral treatment for diabetes that isn't very popular in Australia. Some of you might know about acarbose. It can certainly cause diarrhea. A few people might have been exposed to a medication called Byetta. I mentioned that GLP-1 hormone. It's a synthetic version of that hormone. And diarrhea is a side effect in a few people using that drug. Some of you might know about a medication called Orlistat or Xenical, which stops fat absorption from the intestine. That can cause problems with diarrhea. And then there are some artificial sweeteners, not all of the artificial sweeteners, but these ones in particular, which can be present in some food products, can also contribute to diarrhea. Many of those, in fact, are used as laxatives in the right setting. The small intestine function is quite often disordered in people with diabetes, and people with upset stomach function often have upset small intestine function as well. The movement of contents through the intestines is very variable in people with long-standing diabetes. Often it's normal, sometimes it's abnormally rapid, sometimes it's abnormally slow. So a very wide range between different individuals. If you've got contents that aren't moving through the small intestine as quickly as they should, you are at risk of getting excessive growth of bacteria in the small intestine, and that can contribute to nutritional problems and diarrhea and bloating and various symptoms like that. We can diagnose that by putting a telescope down and sucking out some fluid and culturing it in the lab. We have got some breath tests that can be used to diagnose it. They're a bit less reliable than aspirating the fluid, and it's treated with different kinds of antibiotics. So if you're looking at causes of diarrhea in people with diabetes, particular things you think of are that bacterial overgrowth. A controversial area is whether the part of the pancreas that makes the digestive juices often might not operate normally in people with diabetes. There's some suggestion that a small percentage of diabetes, this may be a problem, so we ought to think about that. People with type 1 diabetes, which is what's called an autoimmune condition, are at increased risk of celiac disease. Celiac disease is where there's an abnormal immune response to gluten in the gut. Many of you will have heard of celiac disease. About 1% of the general population has celiac disease, but probably about 5% of people with type 1 diabetes. So there is an increased risk of that. There's a fairly uncommon condition in the colon called microscopic colitis, which is also slightly increased in people with diabetes. And the other thing that as specialists we always ask people about is fecal incontinence. This, if you don't like talking about diarrhea, you definitely don't like talking about fecal incontinence. If you send out surveys, you might find that even 5% of people in the community actually have fecal incontinence, and it is definitely increased in risk in people with diabetes. So if this is a problem for you, don't hesitate to take the problem to your doctor, because it's the sort of thing, unless doctors ask specifically about, no one wants to talk about it. Finally, I've mentioned that there is something called diabetic diarrhea. It's something that we see very occasionally, usually in people with long-standing type 1 diabetes, and it probably relates to the disorders of gut function that I've talked about already. Constipation, another thing that people might not like to discuss. Constipation again means different things to different people. It might mean you don't go to the toilet every day. It might mean that you pass very hard stool. It might mean that you have to spend a lot of time straining when you try to pass stool. And specialists like me spend a lot of time dissecting out these symptoms with people, and we're not embarrassed talking about it at all. Up to 60% of people in specialised diabetes centres tend to report constipation. In the more general community, people with diabetes are rather less affected, but it does seem to be a slight increase over non-diabetic people. Whenever people come with a change in bowel function which is recent, we always want to think we should make sure we rule out bowel cancer. So that's a change in bowel habit is an alarm feature, and we think about other things like, is there bleeding? Is there a family history of bowel cancer? They're the sort of things that go through our minds. We would certainly again consider whether medications might be contributing to constipation. One of the group of medications that's often a culprit is opiate painkillers, but there are a number of others. How broadly should we treat constipation? Behavioural change is an important thing. For instance, taking advantage of the right time of day to be sitting down on the toilet. The bowel has an increased activity after meals, so that's a good time to give the bowel an opportunity to empty. Fibre in the diet is one of the basic natural things to do to help bowel function. It's not always the answer, but it's one of the first things we turn to. And then, of course, there are various laxatives which work in different ways and which we would use in some people. There are a proportion of people that have problems despite all of this, and they might need some specialised evaluation in the right kind of setting. So we're very close now to the tail end of the talk. I want to recap on the key points that I've talked about today, and these are that both type 1 and type 2 diabetes are associated with symptoms at pretty much every level of the gastrointestinal tract. But the relationship between symptoms and abnormal flow of contents through the gut, it's there, but it's relatively weak. Abnormal blood glucose can exacerbate symptom and function related to the gut. But what I hope I've convinced you of today also is that gut function, in particular the rate that food empties from the stomach, is a major component of blood glucose control after meals, and it's something that we can maybe manipulate to therapeutic gain. So the last thing I want to do is to acknowledge the people that I work with in research in this area. I've mentioned Michael Horowitz, who has been doing this for about 30 years now. Karen Jones, who's done a lot of the work with the nuclear medicine technique to measure stomach emptying. A basic science colleague, Richard Young, who's doing a lot of work with me looking at how the gut senses glucose. And research students and postdoctoral fellows who have worked with me in recent years. The bottom name on the list, Linda Mignoni, is here today, and in a moment Linda's going to just spend 5 minutes talking to you a little bit more about some of the things that we're doing in our research interests at the moment. But it might be the opportune time at this point to have a little break for questions and see what you'd like to ask. So thank you for your attention.
Just wanted to ask, there's been some research about having gastric bypass to help control diabetes. In that case, how does the digestive system work, not passing through the stomach and activating some of these hormones?
Yeah, this is a fascinating question, and many of you might have heard that this is a big topic of research interest at the moment. There are a number of weight loss operations that get done. One of the popular ones in Australia had been gastric banding, where an inflatable band gets put around the top part of the stomach, and that kind of just restricts the food to a smaller upper portion of the stomach, so you fill up quite quickly. And it is somewhat useful for weight loss, but people often tend to regain a lot of that weight. There's another operation called gastric bypass, where you're left with quite a small stomach reservoir that empties into the small intestine fairly quickly, and the actual anatomic arrangement of the gut is rearranged. And it probably results in better weight loss than gastric banding, and it seems that the weight loss is maintained over a long period of time much better. Now, the evidence seems to be for people with type 2 diabetes as part of their obesity, probably the gastric bypass operation is a better operation, And we're trying to work out the reasons for that. Weight loss in itself, of course, however you achieve it, is going to be good for control of type 2 diabetes. But there are lots of other things going on. One of them is the fact that the contents are being directed more rapidly to the areas of the gut that secrete some of the hormones that we're interested in. So, for example, if you look at what happens to those GLP-1 levels after a gastric bypass, they tend to go up very prominently once you've had a meal. So that's probably one of the factors. But there are a lot of other mechanisms. What happens to bile flow? Bile flow seems to be an important regulator of blood glucose. What happens to the bacteria that live in the gut? That seems to be changed after a gastric bypass operation. What happens to how the gut's actually metabolising glucose itself? There are many different aspects of this problem that people are actively examining at the moment. But the bottom line is that, yes, gastric bypass for people with obesity and type 2 diabetes seems to be a very good operation, and it seems that it's probably beneficial to get in early, and if you're going to do it early on to prevent some of the complications of diabetes and reverse diabetes as quickly as you can.
Yes, Doctor, good morning. Over the last 30, 40 years, I've suffered with IBS in various stages, several operations to counteract the reflux and diarrhea. So you've got both ends of the spectrum. Now, you mentioned celiac disease. I'm just wondering the interreaction of the IBS, the IBS and the operations with the control of diabetes after you've been diagnosed with it. I don't have it, but I'm just concerned that the control of the diabetes will be so much more difficult because of those operations in the IBS.
Operations in IBS, what sort of operation are you thinking of?
I had Nissen fundoplication.
So operation for reflux?
Yes.
Yep.
Pyloroplasty. I had one of them 40 years ago. And that was all because of reflux, acid, as you said before, acid coming up and food coming up. I just wondered, now that's been generally controlled. I'm just wondering though, that with the control of your diabetes, having had those issues before.
Probably the operation for reflux, which is where the top part of the stomach gets partly wrapped around the bottom of the gullet to actually prevent reflux from happening. It's a very widely done operation now, often with keyhole surgery. It's quite a useful operation for people whose medications alone don't control reflux. It probably doesn't have major effects on blood glucose control. One of the things it might do is make you eat a little bit more liberally of those fatty foods that used to set off reflux symptoms, and now your reflux is controlled, you can feel you can eat them much more easily. So that might be bad for your diabetes control. The reflux operation can sometimes slightly affect people's stomach emptying rate, but it's not a major effect. So in itself, I wouldn't expect major issues. If it's been complicated, occasionally it gets complicated by nerve damage that does affect stomach emptying, and then it could be a problem. But that's pretty unusual.
Good morning. You mentioned the impact of erythromycin and stomach emptying. Is there any relationship between taking erythromycin on a long-term basis and the onset of diabetes?
So the question would be, could it induce diabetes? I think probably not. I guess people would be few and far between who take diabetes long term. There might be a few who take it for reasons of needing an antibiotic for one reason or another. There's mixed evidence as to whether the effects on stomach emptying are sustained in the long term, actually. So we know that if you give the drug by injection as a one-off, it has big effects on stomach emptying. Probably if you keep taking it over a prolonged period of time, the body gets used to that drug and the effects are rather less. So some of the evidence suggests that, particularly in tablet form, erythromycin may be rather less effective at changing gastric emptying than it is when when an injection's given as a one-off.
Would you recommend taking whey powder before you eat?
So-
And I once before did it. I lost 5 inches. I don't know how much it is. 5 inches off of here. So would you recommend that before you eat? And would that be a big help?
So certainly the studies that I showed you, which were just one-off doses of whey, they looked like it would be a good idea. What we're doing at the moment, and Linda will tell you a little bit more, is that we're giving it to people twice a day to have before 2 of their main meals on a 12-week basis. And we're studying it in a controlled fashion. So some people have the whey protein and other people have what's called a control, something that doesn't have the whey protein, and they're each taking it about 15 minutes before meals, and we're seeing what happens over 12 weeks. Our initial results seem to be positive, but we're still completing that study at the moment. So things like what it does to weight, will the effects be sustained over long-term use? Yeah, so, and are there any side effects that we need to know? These are the things that we need to study on a scientific basis before we can recommend it widely. But I think the early results are very encouraging.
Just the last question over here.
How much quantity of the whey drink?
So in the study that I showed you, we used 55 grams of whey. The amount that we're using in our 12-week study is more like about 20 grams per serve. Fascinating, the sort of history of whey. Whey is a byproduct of cheese manufacture, which Linda will tell you, and they used to throw it out. Then the bodybuilders got on the scene. You've probably seen these people buying huge tubs of whey and shoveling it in with each meal to try and build up muscle bulk. Maybe you could do that too if you came to our study. I'm not sure if we're giving enough for that purpose. It became really expensive. So whey has that's another factor that not only do we want to restrict the amount we have to give you because it involves some extra calories, but the stuff actually could be expensive if you had to take too much, and you have to have something that's affordable and achievable at a low cost. So that's another reason to see if we can minimise the dose that's needed to get the beneficial effects we require. So I think we might move on, if there are no further questions, to getting Linda to come up and having a brief talk to you.
Thank you, Chris. That was another interesting discussion. So thank you very much. I think we've all learnt a lot. Thank you.